My name is Brian Wood, Medical Director for the Mountain West AETC ECHO. Welcome to this week's session, and I will turn it over to today's speaker.
In discussing what kind of topics we wanted to discuss, I thought we would do this topic today because there was actually a lot of discussion about this at the ID Week meeting recently around same-day ART initiation, as more and more places are looking into this as an option. So before, I wanted to just briefly highlight that there were new treatment guidelines that came out on the 17th, and there will be a more detailed review of the updates next week. But I just wanted to highlight a couple of the changes just in regards to the initial recommendations for treatment in terms of regimens. That essentially that integrase inhibitor-based therapy is what's recommended for most people. So they have two new categories of initial regimens, essentially what's recommended for most people and then certain clinical situations. And pretty much everything else is in the other certain clinical situations. So protease inhibitor-based therapy, including darunavir and NNRTI-based therapy has moved to this category, and there'll be some more detailed discussion about what that means certain clinical situations. All right, so I wanted to start off with a case and a audience response question. So a 30-year-old gentleman presents from the STD clinic with a new diagnosis of HIV. He was just told this morning that he has HIV. He's asymptomatic and was tested because he had condomless sex with multiple male partners in the last 6 months prior to coming in to get tested. He actually denied any acute illness recently, doesn't recall any kind of acute syndrome that would be consistent with seroconversion. He is housed. He denies any other medical problems. So, would you start ART that day? These are all really valid concerns about why we have the traditional algorithm has been to wait and get more data, get a sense of where this person is in understanding their diagnosis and the expectations for adherence. So I wanted to bring up some recent studies and the background and rationale for some of these studies being done. So we do know that there's a high loss to follow-up rate between testing and ART initiation. And when we look at the care cascade, that really confirms that. Between that testing and engagement in care and retention in care, there's that bigger drop-off. Once people are in care and on antiretroviral therapy, a high percentage of them actually do get suppressed. So this is an attempt to sort of address that loss to follow-up in between testing and ART initiation, or at least engagement. Of course, we want to think about it as a public health intervention as well, and there's increased risk of transmission to others prior to ART initiation. So the sooner that you can get someone suppressed, the better it is as a public health intervention. And we know that from other studies, not looking at same-day initiation, but looking at delayed versus more immediate initiation, and there were varying lengths of time when we talked about immediate, most of them within 2 weeks rather than same day, there was higher mortality in the delayed start compared to the sooner immediate start. Again, those other studies really looking at a 2-week interval rather than same-day interval. So the first study that was published was last year in sub-Saharan Africa called the RAPID study. And this was a randomized control trial looking at initiating antiretroviral therapy for HIV at the first clinic visit. And this was done at a number of different, actually, one particular clinic actually. First there was an HIV screening and consent for an enrollment, and they were randomized to either the rapid initiation or standard. And a lot of the things that you all were talking about in terms of more data needed was done during the standard initiation procedure. So getting samples of CD4 counts, doing a symptom review for TB, getting those results at the second visit, and then addressing the TB or other OI prevention sort of things that you need to do. Visit 3 is to provide counseling on adherence and education at a group setting, and then more individual settings. So as you can see, that there was a number of procedures at this clinic that were happening, a number of visits, 6 visits before you get started on antiretroviral therapy. As opposed to the rapid initiation where everything was done, the same number of tests were done, but there was no delay. We did no waiting for those test results to come back the ARVs were dispensed as long as the patient was asymptomatic and didn't have signs and symptoms of active TB. And then these patients were, as you can see, this is sort of the breakdown, about a little over 200 patients were randomized to each of the groups. And as you can see here in this table, and this is really what the meat of the results is. Essentially, for patients who started in the rapid arm, they were not only did they get on treatment sooner, but more people actually got on treatment. With the delay, only about 75% of people in the end ended up on treatment at any given time afterwards. And they looked at 200 days after enrollment. So by delaying, there was already 25% of those patients were lost and were not recaptured in terms of getting on ART. So the benefits from this study is really not only getting people engaged sooner and getting on treatment sooner, but actually staying in care and remaining suppressed. So offering single visit ART initiation to adult patients in South Africa in this study increased uptake of ART by 36% and virologic suppression by 26%. So pretty significant results, but again, this is in a different setting than what we all, even in the echo community, a lot of our practice sites are very different. I mean, Dave has patients that are all over the place, whereas we generally have a smaller geographic area where we're seeing patients. So there was another study, a similar design, done in Haiti. This was done with Harvard researchers that have a research site at Port-au-Prince in Haiti. Similar procedure, either the standard 6-visit initiation protocol versus same-day initiation protocol with similar screening for active TB and active OIs, and then if those are negative, starting ART. And so this also had a number of patients, and these are the results. This looks like the exact same graph because it essentially is the same exact results duplicated in Haiti, where you see that drop-off of about 25% of patients with delayed initiation that you can't really recapture. And that's the crux of it. When we don't start ART, at least in these particular sites, we lose a percentage of patients that are then difficult to engage later on. The results were similar. ART initiation is feasible and beneficial and improves retention and care and virologic suppression. So interestingly, they also looked at some qualitative results. They found that the patients felt that the diagnosis was really traumatic, and having all of those wraparound services provided at that same day visit. I mean, Dave alluded to this 1.5 hour or more process where they get this intensive counseling and hand-holding during that process and getting started on meds, as opposed to saying, okay, here, let's draw some blood and come back and see me later. There was increased hope and connection to care with the same-day ART when they looked at the qualitative surveys from the patients who participated in the study. There obviously are barriers. So there was a lot of waiting around on that day. I mean, essentially, patients were told, you'll have to be here pretty much all day, getting these tests, getting your clinical assessment, getting adherence counseling, doing financial applications if that were necessary, and then waiting for the meds to be dispensed. Transportation costs are also barriers. So for people that are having to come back 6 times for visits, this is actually a downside for the standard protocol where you have to return so many times for so many visits. And that the costs of actually leaving work potentially for the transportation itself to come to these visits were also barriers. So the WHO recommendations that came out in July of 2017 of this year actually do comment on same-day ART initiation. The WHO recommendations are rapid within 7 days. ART initiation should be offered to everyone following a clinical assessment, and that clinical assessment again ruling out active TB mostly, and is what they're alluding to. And then ART should be offered on the same day for those who are ready to start. So that's a pretty strong statement. So within 1 week, or if not within 1 week, I mean, maybe even within the same day. And the goal really is to improve linkage to care and reduce the loss to follow-up that we saw in both of those studies that I presented. The clinical assessment, I just wanted to kind of highlight what they felt was necessary. A history and exam to assess for opportunistic infections. If asymptomatic, then okay to start. And then for patients with low CD4 counts, so less than 100, it does include considering a CRAG, which is actually in our guidelines, OI guidelines here, or empiric fluconazole if they're asymptomatic and CRAG testing is not available. So I wanted to highlight just a little bit of data within the US actually. So same day or next day appointment for newly diagnosed patients in San Francisco. This is a much smaller study, only about 39 patients, where they met with an MD, RN, social work, financial advocate, labs were drawn, medication given, they were followed up closely within 1 week and transitioned to an actual PCP. So they had a different provider that was sort of on call for new starts and new diagnoses. And so this is was just published recently, this rapid ART start. And I just wanted to highlight that 25% of these patients actually had acute HIV infection. There was a lot of comorbid mental health, substance abuse, and homelessness in this population. So not, cherry picking the best of the best who is going to be adherent necessarily. And what you can see again is that this is a 30-month follow-up period. The rapid patients got on ART, and the proportion of patients who were undetectable or less than 200 copies was significantly higher than in the CD4 guided therapy. Hopefully nobody's doing that really anymore. Everybody should be on ART. The outcomes for virologic suppression weren't different, but the time to virologic suppression was significantly shorter in the rapid ART start. So time to virologic suppression was essentially 56 days in the patients who got ART right away. The treatment guidelines that just came out actually do have a paragraph about same-day initiation, so I wanted to highlight what the US guidelines say currently, which is that same-day start approach remains investigational because of the data that the only data been published that was small data in San Francisco, and they felt that the single site studies in sub-Saharan Africa and Haiti didn't necessarily translate to the US setting. And they say that the data is not yet enough to support that. And they do highlight that this approach is very resource intensive. So the need for on-call clinicians, so as soon as someone's diagnosed to say, okay, I'm ready to meet with this person, do a complete visit, order all the labs, for RNs to be available, and very importantly, for social workers to be available to not only see the patient, evaluate the patient, but do the appropriate insurance coverage paperwork and counseling that's needed. So very resource intensive at that initial visit, but again, weighing that with the improved engagement and care, reduced loss to follow-up. There have been some other studies that are not yet published, particularly in Atlanta where they did this pilot. That did not go well because they have over 6,000 patients in that clinic that they looked at. And in that time period when that study was evaluated, they had 100 new diagnoses within a 6-week period. So they just could not manage this resource-intensive approach. So I think it's really probably clinic and site dependent at this point, whether you can take that on.